Alrighty, and with great pleasure, I have the extreme honor of announcing our guest speaker, Dr. Christian D. Ramers. Dr. Ramers is the Chief of Population Health and Director of Graduate Medical Education at the Family Health Centers of San Diego, a large federally qualified health center system serving nearly 200,000 medically underserved individuals throughout San Diego County. He is board certified in internal medicine, infectious diseases, and addiction medicine, and is particularly interested in HIV, HBV, HCV, and service of medically underserved immigrant and refugee populations. He co-chairs the California chapter of the American Academy of HIV Medicine and has advocated for HIV and HCV care at the state legislative level. He has served as a consultant for CDC-sponsored HIV, HBV, HCV educational projects in Asia and Africa. Since 2018, he has served as a senior clinical advisor for the Clinton Health Access Initiative's Global Hepatitis Program, working to eliminate HBV and HCV in 7 partner countries in Asia and Africa. Since the onset of the COVID-19 pandemic, Dr. Ramers has taken on a leadership role in policy, laboratory, public health, research, and clinical response. He is a core member of FHCSD's COVID-19 response team, delivering bi-weekly updates to over 200 clinicians and staff. At the regional level, he serves on the County Clinical Vaccine Advisory Committee and Equity Task Forces. He is a member of the National IDSA CDC Clinical Call Escalation Volunteer Group, and he has facilitated several telemedicine forums, including one on HIV care at the International AIDS Conference, a 10-week intensive telemedicine series, Telemedicine Hack, supported by HHS, and a COVID-19 outpatient therapeutic series supported by HHS and Project ECHO. Internationally, he facilitates a twice-weekly Spanish language COVID-19 virtual community of practice for Latin America and has presented at an internal WHO AFRO region webinar on SARS-CoV-2 transition. Dr. Ramers, thank you so much for joining us today. We are absolutely thrilled and pleased to have you on board, sharing your expertise on COVID-19 with our community. And with that being said, the floor is all yours.
Thank you so much, Crystal. Can you hear me okay?
Yeah, sounds good.
Great. Okay, so it's great to be with you. My pronouns are he, him, and elle. I'm going to share my screen, and I've put together, I think, way too many slides. And I'd like to spend a lot of the time going through questions and answers. So I think we're shooting for maybe 20 to 30 minutes of a talk and then the rest for questions. Does that sound right?
Yep, sounds good.
Okay, great. So I know the focus is going to be back to school and school risk mitigation and stuff. And I'm definitely going to get to that kind of towards the end, but I think it's important to just really start with the basic facts. This has been a pandemic of misinformation more than anything else. And yet the science has happened so quickly that even keeping up with the real facts has been difficult. So let's kind of start by agreeing on what is real. So we'll start with the basics of COVID. And then I'll go through, I think it's important to just understand epidemiology. All this depends on what's going on in your local community and around the world. Everybody wants to hear about variants, especially the Delta variant. I'll talk about that a little bit. Touch briefly on vaccines, and then really finish with COVID in children and what that means for our schools. Okay, so I'm going to start just with the very basics. What is COVID? Some people don't even believe this is a real thing, and that's really a tragedy because it's definitely a real thing. These coronaviruses have been seen in electron micrograph pictures on the top right here, and they get their name coronavirus because of the crown that they have on the outside of them. Those are those spike proteins that stick out. It's a family of viruses that's really been around for a long time. In fact, the regular coronaviruses cause 30% of all colds that people have every year. And then there's these sort of emerging ones called SARS and MERS that have been kind of much more virulent, much more pathogenic than the other ones. I'm going to show you on this slide kind of the family tree of coronaviruses on the left-hand side, and then all the names of them over on the right-hand side. And these have names that you would never remember, like 229E and NL63. But the newer ones that are high pathogenicity are the SARS-CoV that came in the early 2000s, and then MERS, which came a little bit later. And then we now have SARS-CoV-2. And so COVID-19 is really the clinical illness that's caused by SARS-CoV-2. And we understand a little bit about coronaviruses, and we've been working on vaccines for 15 to 20 years against coronaviruses. This is not really anything new. Now, how do they transmit? I know I saw a couple of questions come in about this, and it's really, really important about mitigating your risk going back to school, understanding this in detail. So this is an article from Science Magazine that's just very recent by Wang et al. That kind of goes through all that's known about this. And I'll explain to you why I'm sitting here wearing my N95 mask. There's really good reasons behind it. Now, from an infected person on the left-hand side here, there's really, let me see if I can use my pointer or a pen. Yeah, okay, hopefully you can see the little pen marks. This is the infected person over here. Someone who has COVID has lots of viruses in their nose and in their mouth and in their lungs, and they can basically transmit it in a couple of different ways. The first is through droplets. And if you're close enough to somebody who's speaking or breathing or talking or singing, these droplets can actually just sort of hit you and enter your airway right away. Those droplets tend to be bigger in size, and they tend to fall towards the ground in about 3 to 6 feet. That's this sort of this arc right here. Those are the bigger droplets. In the beginning, we thought droplets were really the only way for transmission, and we didn't really think anything about aerosols. Aerosols are actually smaller sized particles that can go straight out and actually can hang out in the air for quite a while. Those can go out over here, and they can actually be breathed in by other people that are farther than 6 feet away. Kind of in the middle of that is something called fomites. And fomites is when the droplets kind of fall on the floor or on the surface of a counter or something, and you touch it, and then you touch your mouth. We don't really think that fomites are that big of a deal anymore, so you don't really have to bleach your groceries or all that kind of stuff. It's certainly a good idea to wash your hands and to wash surfaces anyway, because there's plenty of other viruses that you can get. But it looks like mainly droplets and aerosols are the two main ways that transmission happens. How much each of those two contributes is up for debate, but suffice to say, I think most transmission is probably from droplets, just getting too close to people that aren't wearing masks. And then there is some aerosol transmission. So here's what this looks like, is you have these different sized droplets, and they can have little viruses inside of them. So whether the droplet is big or small, or whether it's an aerosol, there's definitely viruses in there. And over on the right-hand side, I'm going to get into a little bit of physics here, which is that the diameter of the droplet correlates with the number of hours that that droplet's going to stay in the air. And so the smaller the droplet is, the smaller the diameter, you can get all the way up to hours, so 1 hour or above in certain size droplets that are here. And as an example, I'm going to just show you that a 100 micron size droplet that's dropped at a height of 1.5 meters, 5 seconds, and that's on the ground. But a 5 micron size droplet that's dropped or breathed out spends 33 minutes in the air. And then a 1 micron droplet that still may have virus in it can stay in the air for 12 hours. So I'm just finishing a clinic where we had 25 patients coughing all over our clinic who had really bad COVID, probably very high viral loads. We do have HEPA air filters, but I'm not taking any chances. There's probably tons of COVID in the air in these aerosolized droplets. And so you need to think about that going back into a school environment about how that's going to impact your risk. Obviously, masks are a good idea and they work. This is just not even debatable anymore. And the people that say that the data is contradictory on masks or that masks are harmful, it is completely not true. They must have seen it on YouTube with something that's just not accurate. Masks are absolutely been proven over and over and over again to be helpful in decreasing the exposure, both from the person wearing them, that's going to protect them from coughing and breathing out more particles, who has COVID, and then the person that's healthy, wearing a mask protects you as well. The one thing in this picture that's been criticized a little bit is that there's no eye protection, and people that are really close can actually cough or breathe those droplets right on people. That's where I wear my eye protection when I'm seeing patients. I don't really need them anymore. But there's plenty of studies showing that if you implement a universal mask policy, on the top A panel here, this is New York City that implemented a face covering policy that was mandatory right here. And you can see the COVID rates, nothing else really changed that much. There was no vaccination at this time. COVID rates went way down after implementing that policy, whereas the rest of the country that didn't have any masking that was mandatory, the COVID rates stayed about the same. I could show you 100 other studies that really show the same thing. And this is why all the general recommendations for schools are that universal masking is a good idea. Now, it's true that not everybody that gets COVID is going to get really sick with it. This is from the original data from China, from the Wuhan outbreak, 44,000 people, and 80% of them had what's called mild disease. Now, those people probably wouldn't tell you that they had mild disease. They didn't feel very good, but those are people that didn't need to be hospitalized. You can see that about 15 to 20% of people will have severe or critical disease. The thing that's tough is that it's unpredictable who's going to be in that category. We can guess a little bit by age and by comorbidities. The people that are obese or have heart and lung disease or immunosuppression are more likely to be in the critical side. But things are kind of changing with this Delta variant, where we're seeing younger and younger people fall into that severe and critical category. With this slide, I'd just like to make the point that COVID is really a 2 to 3 week illness. And people generally say after 3 to 4 days of flu-like symptoms, they might start to feel a little bit better, but they're really not out of the woods. Typically, the incubation period, where the time after you're exposed to getting the virus and getting sick, getting symptoms, is about 5 days. Usually takes people 3 to 4 days to get a test and get a test result. And then there's sort of the 7 to 10 day period, which is really critical, where it's sort of towards the end of that people actually get really, really sick and have their oxygen levels drop. That's when they need to go into the hospital, and people typically spend a couple of weeks, maybe 2 to 3 weeks in the hospital before they die. So this is a whole month-long process. The deaths that you're seeing today from COVID are from people that caught COVID probably 4 to 6 weeks ago. It's also been appreciated that COVID is really a two-phase illness, where there's an initial viral phase. Your viral load, your viral levels are at their highest at the very, very beginning. And then the virus is almost completely gone by 10 days in. That's why if you get COVID, you're really not really considered contagious anymore by about 10 days in. But interestingly, that's when the immune system starts to take over, and it's actually an over-exaggerated and exuberant immune response that really causes people to get very, very sick in the second phase. That's actually why steroids work so well against really severe disease, because they calm down the immune system. Okay, I'm going to zoom through some of the global numbers here just to show you. This is the Johns Hopkins dashboard here, where we know that there's now 217 million cases that have been documented, 4.5 million deaths, and then amazingly 5 billion vaccines that have been administered, really the biggest vaccination campaign in the history of the world. On the left-hand side, you can see the US, unfortunately, is leading the world with 640,000 people that have died of COVID. The global snapshot is a little different. We've had surges, and surges always naturally recede. But really overall, still about 4 million new cases every week. Our death rates are sort of flattened out here. Our case rates are sort of flattened out here. We're kind of all in it together, and you have a surge somewhere in Africa, and then a surge in Europe, and then a surge in the US. It's all kind of going back and forth. Currently, the US really is the most number of cases in the world by far. India is number 2. And then Iran and the UK are having resurgences, and Brazil, which has just had a very, very high number of cases, is now finally on the way down. I want to show the UK because it's an interesting example. They tend to be 3 to 4 weeks ahead of us in many things. And the UK has had a very big surge of this Delta variant, which happened in July and August, as you can see right here. But look at the difference between the surge they had in the winter right here, where the number of cases correlated with the number of deaths really almost linearly, 1-to-1, versus this new surge that they had with Delta, and the death rate only went up just a tiny little bit here. I think this is a little glimpse into our future, because the UK had a fairly good vaccination rate with 64% fully vaccinated and 72% that had at least one dose. And when you have that type of situation, even if you have a ton of cases circulating around, you're not going to have a lot of serious disease and death. A lot of people get sick, and that's a bummer for them. But if you're vaccinated, at least you're mostly protected from getting severe disease or dying from COVID. Keep that picture in mind where you have a bad surge with low deaths, because it's exactly what's happening in California right now. Here's the US. We're kind of on fire right now. This map has looked a whole lot better if we go back a month or two, but the Delta variant is just being very, very transmissible, especially in the Southeast and places that have low vaccination rates. So as of August 31st, we had 160,000 cases a day, 100,000 people in the hospital, and we're now over 1,000 deaths a day in the US. Keep in mind, this is going to get worse because these are delayed by about 4 weeks. And then our cases, hospitalizations, and deaths here, really not looking great. I think a lot of this death number over here on the right-hand side, this is almost all unvaccinated people. You'll see in California how things look a little bit different. But it's really a regionalized epidemic. So state by state, things happen at very different rates. Right now, South Carolina is kind of the latest southern state to really surge, where there's just a huge number of cases, 100 cases per 100,000. That's a very, very high rate, as you can see kind of right there. And then the vaccination rate in that state is about 43%, so quite low. We've already had surges in Alabama with low vaccination rate, Tennessee. Florida's not bad. The vaccination rate, I think, reflects a lot of the older people that are there. And then we have to go all the way down to number 34 to find California here, which is amazing since we have the most populous state in the union, but our rate is right now only 35 per 100,000, so quite low. And our vaccination rate, you might say, yeah, this is great. In San Diego, they just announced 75% of eligible people are vaccinated, but the overall population, only 56% in California are fully vaccinated. And I'm going to skip through this because I don't have too much time, but California, just so you see it here, here's our dashboard. Our number of cases are having a surge here, you know, not as terrible as many other places in the country. But remember, I showed you the UK. With that number of cases, our death rate is just a tiny little bump here. So yes, people are dying. They're almost exclusively vaccinated, but it's not one-to-one. It's not correlating the way it did in the old winter surge. You know, not to say that healthcare workers aren't really still getting creamed with a lot of cases. We're having a lot more hospitalizations here, a lot of ICU stays as well. And like I said, almost all unvaccinated people. I'm going to skip through San Diego. We used to have a colored tiered system. Everywhere is purple now. We have high transmission really everywhere because of the Delta variant. And what San Diego County is now doing is they're reporting case rates and hospitalization rates by vaccine status. So this is kind of from March going forward. The blue dotted line is the number of cases overall. And you can see that we've definitely had this little surge here. But when you separate by unvaccinated in the orange line here, it's way higher than vaccinated here in the green line. Now this shows you that vaccinated people are still getting COVID. That's probably because of the Delta variant kind of being so much more transmissible. But I'll show you in a little bit, a lot of these people who are vaccinated are not really getting that sick. But suffice to say, the rate of COVID in people that are unvaccinated is 4 times higher than those who are vaccinated. What about hospitalizations? Well, it's even much more of a marked difference. So again, overall hospitalization rate in blue here. Unvaccinated hospitalization rate is up there in orange, and vaccinated, it's very, very rare for people that are vaccinated to need to go to the hospital. So in fact, overall, it's 86 times more common, the hospitalization rate is 86 times higher in unvaccinated people compared to vaccinated. And now they're starting to publish all 3 of these numbers together. We've got not fully vaccinated in blue and fully vaccinated in orange. And the cases, as you can see, are mostly blue. The hospitalizations are mostly blue, almost all blue, at least in the last couple of weeks. And then the death rate here also, most of the deaths happening in unvaccinated people. And the summary numbers are down at the bottom. So 83% of cases in San Diego, I think this is since March 1st in unvaccinated, and 96% of the hospitalizations and 89.5% of the deaths. So if you're looking for data to support why you should get vaccinated, here it is. You know, 86 times higher risk of getting really sick and hospitalized if you're not vaccinated. Okay, just 1 or 2 slides on variants. This is kind of confusing to people because the nomenclature is really complex, but variants are essentially just accumulations of mutations in these viruses, especially in the spike protein. That's what you're seeing on the left here. And these mutations, viruses mutate. It's just what they do. And when they make copies of themselves, they don't make perfect copies, and you have mutants that accumulate these differences. And the Delta variant is really just a certain accumulation of all these different mutations in that purple chart that you see up on the top right there. Delta variant, which is also called B1617.2, has just completely taken over because it's just more transmissible than any of the other variants. And that's happened really at the end of June. And it's really responsible for all the surge that we're seeing. So anybody that has COVID now has Delta variant. I can tell you with almost absolute certainty that's because 99.1% of the variants being sequenced now are the original Delta variant, and then another 0.2 and then another 0.1 are cousins of the Delta variant, AY1 and AY2. What does that mean? Well, the Delta variant is actually way more transmissible. It causes 1,000 times more virus in people's nose. This is just a couple studies showing that. With the Delta variant in orange here and red, it's just much higher levels compared to those that were seen in the old original Wuhan, China strain. It has a higher secondary attack rate, as I could show you here on the bottom, which means that much more likely to transmit to other people in your household. That's the triangles here in purple compared to the old Alpha variant down here and the old ancestral variant. And then we even know now that it works faster. It makes people sick faster, 3.7 days on average compared to 5.6. And then there's now data that there's an increased risk of being hospitalized, being admitted to the ICU, or dying. And so the CDC put together this kind of data here, showing you a chart where the fatality rate is on the y-axis here, and the average number of people infected by each sick person, or what's called the R0, is on the bottom here. And we can see all these different diseases here, you know, common cold and flu and chickenpox. Original SARS-CoV-2, or the original COVID, was here. So it was kind of, you know, around the common cold, about as transmissible. What's happened is that with the Delta variant, this has moved up a little bit. So it's actually looking like it's more fatal and it's much more transmissible, about 2 to 3 times more transmissible, to the point where it's almost as transmissible as chickenpox, which is just really, really remarkable. That's why we're seeing everything that we're seeing in terms of Delta. All right, I've got about 5 more minutes and then we'll stop and take questions. So the vaccines. Now, a lot of people say the vaccines were developed so quickly. How can you trust something that was developed so quickly? Well, first of all, COVID vaccines have been worked on since the original SARS-CoV-1 outbreak in 2002 or so. So it's been, 18 years. And mRNA vaccines have been in the pipeline for 10 years or so. It is true that the vaccine development process last year was incredibly fast. From the time that the first cases were sequenced and the genetic sequence was put on the internet to the time a shot went into somebody's arm was 60 days, which is remarkably fast. And then from there to development, it's never been developed that fast ever. People get a little nervous about that, but you know what? We have 4.5 million people that are dead from COVID. So the people in charge wanted to do things as fast as possible. And the Trump administration, through Operation Warp Speed, actually made this possible by throwing about $9 billion to the process and supporting pharmaceutical companies and vaccine manufacturers to take away their financial risk, okay? There's also known processes of vaccine development that are very regimented that go through phase 1, phase 2, phase 3 trials. Usually you complete a whole trial before you even start the second step to make sure that it doesn't fail. And what happened is we did all these things in parallel. So phase 1, phase 2, and phase 3 trials were all done at the same time. That was unprecedented. Many candidates didn't work out at all. We had some vaccines that really didn't work very well. But the review by the FDA committee, the review by the CDC, and then the phase 4 monitoring after these were authorized is all the same that we've done for every vaccine. So all of the safety measures have been in place, and actually our FDA and CDC have been able to detect very, very rare side effects from the vaccines because the systems are so good. A lot of people want to know what's in the vaccines. You may have heard that some people think there's poison or microchips or things like that. Really, you just have lipid particles, which is what the outside is. And we've been using lipid particles for 20 years in medicines. A lot of chemotherapy that we give, a lot of medicines I give to my HIV patients, antifungal drugs are already made in these lipid particles. They're just delivery mechanisms. The RNA is kind of the new part of this. RNA is a very flimsy and flexible molecule that just disappears and doesn't last very long. It's very fragile. That's why you have to keep the vaccines at super low temperatures. And it does not alter the DNA of the people that you inject it into. And then the rest, there's just salts and sugars that are inside that. That's really it in the mRNA vaccines made by Moderna and Pfizer. We have 3 vaccines in the US, the Pfizer, the Moderna, and the J&J or the Janssen. Pfizer's approved down to age 12, Moderna to age 18, and then J&J also down to age 18. And I'm just going to show you Pfizer because that's the one that's really focused on our children and our sort of younger adolescents. They're just incredibly effective. We saw rates of COVID in the placebo arm just go up in a linear fashion here. Rates of COVID in the Pfizer recipients remain almost completely flat in the original clinical trial, and that was in almost 20,000 people in each study arm. And this is what gave us the original effectiveness rates of 95%. So truly remarkable kind of results and very, very safe. In terms of the side effects, I can show you this on here. This is in the publication. The green and the blue are mild to moderate side effects. And most commonly, you're going to see something at the injection site or just a sore arm. About 50 to 60% of people will have fatigue for a day or so. Some people have headaches and muscle pain. And then not too different from placebo in a lot of these things and very, very well tolerated. And I'm not going to pretend that there's not any more severe side effects. I'll get to that in a second. But overall, this is a very well tolerated vaccine, especially compared to many other vaccines that people already get. Now, you might have heard of this thing called myocarditis. The CDC has looked at this very, very carefully because it seemed to be a little more common in younger males. And as you can see the numbers here, these are the reporting rates. The CDC has been tracking this like crazy, and they did see a couple hundred cases of this. So you can see 124 cases in 16 and 17-year-olds, 140 in 18 to 24-year-olds out of like 1 million to 3 million doses. So they calculate a rate of this per million doses of vaccine. And the reporting rate here is like 73 per million or 38 per million in certain ages. Now that's not zero. That's a risk that we need to think about. But let's think about the risk of actually COVID compared to the risk of getting sick from the vaccine. CDC has looked at this, And what you see here is in a theoretical 1 million doses of Pfizer vaccine given to certain age groups. So you can see females on the top, males on the bottom, and then broken down by this age group of 16 to 17, 18 to 24, 25 to 29. In the light blue is the number of hospitalizations that you would expect. The dark blue, the number of ICU admissions, or people that had to be intubated or ventilated. On the left-hand side, if you took 1 million people and followed them through time. If you took 1 million people and vaccinated them, on the right is the number of adverse events of myocarditis you would expect to see. Okay, so you'd expect in the highest risk group, males that are age 16 to 17, 73 cases of myocarditis, and that would be balanced against 500 hospital admissions and 170 ICU admissions. Not to mention there's something called MIS-C, which is a pretty severe condition in kids. And so the risk benefit still absolutely favors getting vaccinated. I'm going to skip through these numbers a little bit just to show you that many, many adolescents have been vaccinated. We're up to 11 million kids aged 12 to 18 that have received at least one dose, and then 8.3 million that have received both doses of Pfizer. And then the San Diego data looks pretty good too. So in the 12 to 17-year-old age group, we have 63% that are vaccinated with at least one dose and 52% that have had full vaccination in the teenage group. And that's even better than the 18 to 29-year-olds. So the teens are lining up even more than the college students. And just to show off, this is my daughter getting her first Pfizer. And she was one of the first kids in San Diego, so she got to get a TV interview and speak to Artie Ojeda from NBC News there. One slide just on what's happening to our vaccine effectiveness since the onset of the Delta variant. And I just want to draw your attention to this calculated vaccine effectiveness from the state of New York. This was published in the CDC journal. And it's gone from 91.7% at the beginning of May, before the Delta variant came along. Delta variant, like I showed you, came along in June, and we've had a little bit of a drop in our vaccine effectiveness because Delta is just a little bit different. It's a much bigger threat to the immune system. But the good news is that the protection against hospitalizations has stayed exactly the same, 95.3% at the beginning and 95.3% at the end. So yes, our vaccines have lost a little bit of their effectiveness in preventing everything, but that was really not the expectation in the beginning. We expect vaccines to allow some infections to get through, and it's still protecting us very well against hospitalization. All right, I'm almost done. I want to run through the pediatric stuff in the end here, just to make sure we all agree on the same facts here. So there's been a lot of literature, a lot of studying about this to show that kids are definitely susceptible to COVID. As they get younger and younger and below age 10, there's a little bit of evidence that they're a little less susceptible, but clearly kids can get COVID. Kids can definitely transmit COVID. I'll show you some data showing they're about as good at transmitting as adults are, but they're less likely to get tested and they're less likely to seek medical care. And that's because they don't tend to get as severely ill as adults do. Lower rates of severe illness for children and adolescents. This is an interesting survey, just a blood survey to see who's been exposed to COVID in this particular outbreak. This was 59,000 people that were tested. And interestingly, the youngest people had the highest rates of actual COVID, probably less symptomatic, but actually higher than any other age group, even over 65. So kids are definitely getting COVID, and they're showing evidence of that in their blood tests. Do they need the vaccine? Well, you don't hear about this a lot, but there have been over 17,000 kids hospitalized. In influenza, in a bad influenza year, it can be 7,000 up to 26,000 annually. And there have been over 500 kids that have died. Some people say, well, those kids all had pre-existing conditions, but that's, who cares? A kid with a pre-existing condition is still a kid, and they don't deserve to die from this disease. They're also an important role in sort of transmitting COVID to other populations. And then I mentioned briefly this thing called MIS-C, or multi-system inflammatory syndrome in children, which is mysterious, not very well understood, tends to happen after COVID infection, where the COVID seems to provoke an out-of-control immune response. And there have been 4,000 cases of this throughout the US and 37 kids that have died of that. Obviously, we think vaccinating kids to prevent infection can prevent MIS-C as well. I'm going to zoom through these really quick. I showed you, or I told you that transmission is equally likely from kids as it is to adults. Just trust me, that's what this paper shows. In terms of symptoms, the light bars here are kids, and the dark bars here are more adults. This is above age 50, and kids are much less likely to have symptoms compared to adults, especially those deep pneumonia type symptoms, only 21% compared to 69% here. We kind of know that intuitively, but here's the data. I'll skip that. And then you've heard probably that kids are spiking in terms of their hospitalizations. And this is true, although the absolute number of kids being hospitalized is way lower than adults. Kids are this gold band right here. Just a little uptick there compared to the adults that are really ending up in the hospital. But when you magnify in on that rate of kids, this is way higher than it ever was in the other times of the COVID pandemic. All right, I'm almost done. What does this all mean in terms of schools? So I'm going to show you 3 or 4 slides that look exactly the same. The first is from the AAP, the American Academy of Pediatrics, and then from the Infectious Disease Society of America and the CDC. And they all line up. What should we do getting kids back to school? And the first thing right up here in the big title from the AAP is that all considerations for school plans should start with the goal of keeping students safe and physically present in school. We all know and we all realize now, especially those of us with kids, that keeping kids out of school is not a good idea. Their learning suffers, their mental health suffers. They need to be able to interact with each other. So how are we going to do that? Well, the most obvious thing, if we don't agree on a lot in society these days, but if at least we can agree that we want to get kids into school, let's use all the tools that we have. So what's the best and most powerful tool? Vaccination. Everyone, whether they're a student or a staff who's eligible, should get vaccinated. Okay, that's rule number 1 of returning to school safely. Not just COVID vaccines, but there's been a big decline in other vaccines. So we really should try to get kids to be up to date on all of their other vaccines that they need to go to school anyway. All children over the age of 2 and all adult staff should wear masks regardless of whether they're vaccinated. This shouldn't be an argument anymore. It's a simple thing to do. If masks are really that harmful, then every surgeon that you've ever met would have problems, and they really don't. I've worn this mask for 10 hours now today, and I'm fine. It doesn't affect your oxygen levels. It's a minor inconvenience. And then beyond that, there's other things that should be multi-layered, like distancing, like testing when you feel sick, or even screening if you don't feel sick, ventilation, cleaning and disinfecting is important, probably less important than the other stuff. And all these things should be offered in order to get your school to operate in person. The Infectious Disease Society of America came out with their statement. It's exactly in line with all this: vaccination, universal mask wearing, physical distance, being outside if you can because the ventilation is so much better, staying home when you're sick, and then contact tracing and testing, notifying people when they've been exposed. And then finally, the CDC back to school guidelines are basically the same thing as well, starting with the principle that in-person learning is best. Vaccination is the leading public health strategy to keep people from getting COVID. And then universal indoor masking by all students, staff, teachers, and visitors. And then 3 feet of distance at least to help with that as well. And then screening, testing, ventilation, other things that can be sort of useful. Okay, the last thing I'm going to say, and then I'll stop talking, is everybody wants to know about vaccines for those below age 12. This is a slide that the director of the VRBPAC subcommittee of FDA presented this weekend on a call that I was on. And he's under a lot of pressure because the American Academy of Pediatrics really wants these vaccines. When can we have them? When can we have them for kids between age 5 and 11? And he says, look, we're not going to rush this. We're going to do this appropriately. We're going to make sure that we look in detail at things like myocarditis and other safety signals, because he said, if we do this wrong, they're going to get attacked by the anti-vax industry and it's going to be a nightmare. So they really want to be careful. They need to make sure that they get the dose of the vaccine right. The dose that's used in adults and adolescents in age 12 is the same as we're using in adults. So they didn't have to really change anything. But there's this concept of dose de-escalation that they need to be careful about. They want to make sure there's no trigger by the vaccine of this mysterious MIS-C thing. And they want to be very careful about adverse events like myocarditis. So he gave an estimate of data being sent to the FDA as early as the end of September at the earliest. And then they usually have 6 weeks after that to try to review the data and make some type of decision. So at the very earliest, we're looking at October for vaccines younger than age 12. All right. Hopefully you've seen in my slides that we think of COVID as very unpredictable. It's definitely still with us. We're in the middle of a really bad surge right now. That's mainly because the Delta variant has been so highly transmissible and it sort of changes the rules of transmission that we learned before. Although kids are less likely to be hospitalized or to die, they are definitely still affected by COVID-19 in very different ways, in mysterious ways like MIS-C, and they certainly are part of the community and can transmit and lead to other cases as well. It is true that schools can be safely opened as long as they use all the strategies they have available to them. And then finally, vaccination is safe and effective, and it's really the best way to protect you or your community against COVID-19. All right, that was a little more than 30 minutes, I'm sorry, but hopefully we
No
have time for
problem.
questions.
You shared so much helpful information. I really appreciate it.
Well, I
And I
couldn't
know
hear
you said
Crystal.
you're going to stop talking, but unfortunately, we do have lots of questions coming in, so I can't give you too much of a breather. Um, but I want to start asking some questions regarding back to school. So one of our attendees asked, if kids and teachers should keep wearing masks at school, what's the best way to handle lunchtime or recess?
Yeah, good question. So it's a fundamental fact about masks. It's really hard to eat when you're wearing masks. So I think the question's about both recess and eating. So the first is eating. When you eat, you're breathing and you're obviously sharing air with people. So the more you can increase the ventilation in the lunchroom, the better. The more you can spread people out, that gets really important. And then if you can do it outside at all, you should do it outside. That's the easiest solution. We're lucky here in San Diego, we have so much outdoor space. So I'd really, really encourage outdoor lunches if possible. Now, recess is a little tougher because, it is much safer to be outside. I think many people have decided that doing sports, you don't probably need masks when you're doing sports. So I would say recess, if you're just kind of sitting around and talking to people, it might be a good idea to wear a mask. But if you're out doing athletic kind of things, you probably could take the mask off. That's a school by school decision. Initially there was a thought that you didn't have to wear a mask at all when you were outside, but there's actually been several outbreaks documented in Oregon and then in Massachusetts where there was significant spread outside. That happens when you just get enough people in a small enough area that the protection from being outside kind of wears off just a little bit.
Now, speaking of masks, what type of mask would you suggest for folks going back to school, whether they're kids or, adults going back to university? Do you think those single-use ones are good enough? Should a cloth one do in combination?
Yeah, the first rule of thumb is you want to wear a mask that you're comfortable in, because if you're not comfortable, you're going to be itching it, taking it off. You got to wear it correctly. So it should be properly fitting. I've seen plenty of patients actually today that had a mask that was just barely touching their face, and they had these big holes right under their eyes. So it's got to go around your nose, got to fit properly. And then there's kind of a gradation of how effective they are at filtering. And simple cloth masks are probably the lowest. Actually, the lowest would be like a gaiter or a bandana. Those don't do much at all. And then cloth masks are next. The more layers that you have, the better. And then above cloth masks are going to be those simple surgical masks that are the simple disposable ones. Those are called blown masks. These ones kind of like here. These are pretty cheap and they work really, really well. They have that metal on the top that can go around your nose. These are much better than cloth masks, actually, quite a bit better. So I'd say these are probably the thing to go to for your average kid. And then the super Cadillac is like what I'm wearing now, which is an N95. And they're supposed to be fit in a very scientific way. They're made to be used around tuberculosis patients and that stuff. I would say if you're going to go on a long plane trip or be in a really high risk situation, this might be something to consider. They don't generally make them in smaller pediatric sizes, so they're hard to find. But that's kind of the gradation. To be honest, I'm in COVID clinic right now, so I wear an N95. But regular clinic, I just wear a plain surgical mask. And when I go to the grocery store, I wear a regular surgical mask as well.
Got it. Thank you. Now, one more school question. Anonymous attendee says, how do I know if my school has good ventilation? I don't know who to ask or how to ask it.
Yeah, that's a hard one because, there are ways that you officially could measure it with what are called end-tidal or CO2 carbon dioxide monitors. But that's a little, that's hard to do. And I've heard people say, don't even try to do that if you don't know what you're doing. So it's more just kind of a regular inspection. Are there windows that are open? Are there HEPA filters? So anything that has a HEPA filter is generally pretty good. They've been tested in specific COVID experiments, and HEPA filters work really pretty well. There's some more advanced things with UV light that hit the central air system. Those are kind of more fancy. I think you just have to ask your principal at the school, and they really should know. Obviously, they haven't been able to completely rebuild all the schools. There's some schools that are pretty old buildings. And so in those cases, originally we wanted to stay 6 feet apart, and with a small classroom, you just sort of can't do that. The very least they could do is put sort of HEPA filters in and open the windows a little bit. But remember, masks are really the more important part. You want to have both. So masks first, and then whatever they can be doing to increase ventilation.
Got it. Thank you. So we're going to go ahead and jump back to more general COVID-19 questions. We'll first start off with, why does COVID cause such an intense immune response in comparison to other coronaviruses?
Well, I think there's going to be a Nobel Prize given out to whoever figures that one out. What I've seen, just to keep it kind of simple, is that COVID interacts with our immune system in ways that most other viruses don't. And it has to do with something called our innate interferon system. And it really is, in some strange ways, able to, at the same time, suppress the immune system and also supercharge it. I think of it as like kryptonite to the immune system. When you move into that second phase, when the virus is kind of starting to go away and the immune system is starting to rev up again, we have seen some inflammatory indicators that are higher than I've ever seen in my career. And I treat people with like heart infections and bone infections and meningitis and malaria. We use things called the ESR and the CRP to measure how much inflammation there is in general in the body. And COVID has produced orders of magnitude more inflammation than most other infections I've ever seen. And that's really why people get so sick in that second week. Again, not exactly sure why it's happening, but it certainly is. And it just has to do with the molecular interactions of the virus with our immune system.
I see. Thank you. I like the comparison with kryptonite.
Yeah.
Makes it a bit more digestible for us folks.
Yeah.
Okay, we have another one. What makes Delta more transmissible?
Yeah, it's just, these spike proteins that sit on the outside of the virus are just proteins, and they're just shapes. They just kind of are shaped differently. And I showed you one slide there with the mutations. They're just little changes in the way that shape looks. And the virus is just doing it kind of randomly. And it's evolution really right before our eyes. When something is stickier and sticks to our receptors easier, then it sort of has a competitive advantage. So it has something to do just with the actual way that spike protein looks, probably sticks to our receptors a little better. What I don't quite understand is why there's 1,000 times more copies of it in people that have Delta variant COVID. That has not really been figured out yet. But they're just simple mutations. And Delta has been really the most transmissible that we've seen so far. Like I said, 2 to 3 times more transmissible than the original SARS-CoV-2 virus that came early in Wuhan.
Right. Thank you. What would it look like to have COVID under control? Do we just have to get used to COVID being around and hope for higher vaccination rates to reduce hospitalization? Or is there a way to actually eradicate the virus? Great question.
Yeah, it's a really, really good question. In the beginning, we had this idea that if we reached herd immunity, that we could just get past it and it would sort of be over. I'm trying to be optimistic, but I don't think that's going to happen. I think that with Delta variant being so much more transmissible, that calculation of what number you need to get herd immunity really has a lot to do with how transmissible something is. So for example, measles is really, really transmissible. And so you need to have 95 to 99% of the population vaccinated to have what's called herd immunity. You have drops in measles vaccination rates and you actually have outbreaks like we had in Disneyland a while ago. We're getting to that point with the Delta variant that it's so contagious that we actually need to sort of hit 95 to 99% vaccination rates. And I just don't see that happening. Mostly because there's people that are anti-vax and their heels are dug in and they just refuse to get it. And so we're just still going to have a susceptible population. So what I think is going to happen is kind of what I showed you in the UK. It's sort of what we saw in the outbreak in Massachusetts, where you still have lots of transmission, but people get sick a little bit and then they very rarely get sick enough to go to the hospital. So I think we're going to, in the short term moving forward, we're still going to see 90% of our bad cases in unvaccinated people. And I just hope that, people that think COVID is a joke and that it's not real, more and more what I'm seeing in my clinic is people that are having loved ones, their parents or their uncle die of COVID. And then it's really hard for them to continue believing that it's not a big deal when they have somebody that's their family member that's gotten it and died, or someone in their community that's gotten it and died. So in the short term, we're going to go forward with a population of people that are vaccinated that still might get COVID, that we call those breakthrough infections, but they get mild disease, and that, it's like a flu. They're home on isolation for a little while. They don't tend to get in the hospital. And then you're going to have people that are unvaccinated that are still filling our hospitals at a 86 times higher rate than those that are unvaccinated. And eventually, we're going to reach a point where everyone's either had COVID or they've been vaccinated. I don't think it's really there was a question I saw that came in here like, I haven't had COVID at all. I've been very careful. Do I really still need to get a vaccine? I think the answer is yes. It's one of two things that's going to happen. You're either going to get COVID or you're going to get vaccinated. So I think that's what our future kind of looks like.
Thank you. I'm glad you brought that up because that was a question in the chat
Mhm.
regarding whether or not they should still get vaccinated. Regarding vaccinations, is it safe for people to hang out together indoors without masks if they're all vaccinated, or should they all get tested first?
Yeah, so it depends on the intensity of the exposure. If you asked me 2 months ago, I would say, yeah, sure. CDC says that if you're vaccinated, your risk is really pretty minimal. But we learned a totally different kind of thing with the Delta variant. If you remember that recommendation came, I think, in April or May from the CDC, where they said, the vaccines look great and people probably can't transmit. You can take those masks off if you're indoors. That was before the Delta variant. That was actually right as the outbreak was starting in India with Delta. And Delta has just changed the rules completely. So we saw in the outbreak in Massachusetts that people with Delta variant, whether they're vaccinated or not, still have high numbers of virus in their mouths and noses. It's actually, that's not the whole story. People that are unvaccinated have high levels and they stay high for a long time. People that are vaccinated have high levels and they go down pretty quickly right away. But still, it's a safer thing to do to be wearing masks. Now, if you're doing kind of like a weekend trip together and it's more of an extended time that you're going to spend with people, if you're all vaccinated and you all test negative, that's relatively safe. And you could sort of plan to create your own little bubble. But it's not a fully foolproof thing to be indoors if you're vaccinated. Somebody could be incubating the virus still and still transmit it. So I think masking is still a good idea. Look, none of these interventions are going to be perfect, not even the vaccines. And so that's why we use multiple things at once.
Now, do you think San Diego County will start mandating indoor masking again?
I think that's kind of a political question. I think we have some county people that are on the line that might have better answers for me.
Right.
There's a lot of people that think it's necessary. The San Diego County Medical Society wrote a letter kind of asking for it. There are many other large cities that do still have a mandate. There's much more than just the science. If we relied just on science, we would say, yes, that should happen. But we live in a society where there's people that get very, very angry when you tell them to wear a mask. And so that's easier to just talk about on a scientific than actually kind of implement. So it's really what it is now is a pretty strong recommendation. And then individual businesses have been, making their own decisions about whether you need to wear a mask on the way in.
Got it. Thank you. So we'll do one more attendee question, and then I have one more question for you regarding treatment. So we'll start off with the attendee question. Someone says, I'm fully vaccinated, but have chronic bronchitis/asthma. I sent my first grader back to school. How worried should I be that she could bring it back and I get really sick? I've thought of changing her back to virtual with the winter coming up and numbers are getting worse.
Yeah, this is a really tough place to be because a first grader is not eligible for vaccination yet, probably. So I think, you've done everything you've done everything right, getting fully vaccinated. The conditions were chronic bronchitis and what else? Asthma?
Asthma.
Okay. So this is where, you have a baseline level of protection from the vaccination. That's great. I would hope that as soon as your child is eligible, maybe later in the year that they get vaccinated themselves. But even that is not going to completely mitigate the risk of bringing home COVID from school. So this is where you rely on everything else. So what else is out there? Well, you would hope that your school has some testing available. You would hope that your other community members are not sending their kids into school sick. And you would hope that if they test positive that you're notified that there was an exposure. Even that is not perfect. So then you think about masks and, should I wear masks? It's hard to wear masks around your family members. They're in your same household. You share the air as well. So the extra things are to not send your child to school if they're sick, to make sure you have a way to get them tested if they have any symptoms at all, and then immediately isolate if you need to do that. And then booster shots. So right now, booster shots are only recommended for people that are immunocompromised. And it's not just a little immunocompromised, it's moderate to severe immunocompromised, like chemotherapy or HIV/AIDS or solid organ transplant. The CDC is going to have a meeting probably in mid-September to talk about booster shots for the rest of the population. And I have a feeling they're going to talk about certain high-risk medical categories like heart and lung disease or immunosuppression. Or other medical conditions. They've already endorsed immunosuppression, and they'll probably have an age cutoff as well, where third doses will be given, and they may even give it to healthcare workers as well. I wouldn't actually mind to get a third dose myself. So I think you got to still be on your toes. Unfortunately, there's not a real easy way to just relax and think that you're fine.
Thank you. Now I want to end this Q&A with hopefully a lighter, hopeful segment, and I want to talk about treatment for COVID-19. So I know there are monoclonal antibody regional centers and treatment with that. Just want to ask, who qualifies for this treatment, and would you recommend it to anyone that tests positive with COVID-19, even if they're fully vaccinated and have very mild symptoms?
Yeah, so you know, it's a difficult thing because if somebody really wants to get it, we're not in the business of turning people away. But I will say that it's a thing about percentages. So if you're 65 years old and you have diabetes and high blood pressure and you're unvaccinated, you have a really high risk of getting in the hospital and dying, like 20 to 30% risk, I would say, in that type of person. And that person really needs to be treated. The monoclonal antibodies could save their life literally. And reduce that chance of being hospitalized by 80% or so. That's really an incredible benefit of giving that. If you're 20 years old and you're fully vaccinated and you have mild symptoms, your risk of hospitalization is like 0.01%. And then it's like, well, what can we do that's better than that? We could give you monoclonals and it's going to give you this tiny little benefit. So I've had those difficult conversations with people every day. And some of them call on their day 9 or day 10, and it's, you know, they're almost at the end of the window already. And, you know, in a shared decision making, some people we've said, you probably don't need it. And some people actually say, I don't want to take the space of somebody else who has a much higher risk than I do. So it's a case by case basis. I think people that have risk factors certainly should think about it and definitely should be the first in line. But technically, the FDA label does allow us to give it to really anybody after we have that risk benefit discussion.
Got it. Thank you so much.
Thank you. I put a link down there as well. That's actually the monoclonal antibody site, but there's plenty of other links to other information on our website too.
Alrighty, well, I suppose that just concludes our segment. And Dr. Reimers, thank you so much for joining us on this call. We know how busy you are, and we just really appreciate you taking the time to, again, just share your expertise with our community and really just highlighting and reminding us that COVID is still very much real.
Thank you so much. Pleasure to be with you.
Thank you. Alrighty, thank you all for attending.